On behalf of the Chronic Liver Disease Foundation, thank you to Intercept Pharmaceuticals for their support of this podcast.
Welcome to the GHAPP CLDF PBC podcast series. My name is Andrea Gossard, your host for today. Today, we are glad to have you with us for our 7th episode on PBC. We will have information today on the importance of clinicians understanding the area under the curve with respect to non-response to ursodeoxycholic acid in the setting of PBC. We are also going to talk about the cumulative effects of non-response over time. Joining me today is Ann Moore, a nurse practitioner and expert in PBC management. She's also a fellow GHAPP member and very experienced provider. Welcome, Ann.
Hey, Andrea. It's great to be back.
Together, we aim to provide a comprehensive understanding of the concept of the area under the curve in response to non-responders to ursodeoxycholic acid, the cumulative effect of not responding to therapy, and the importance of continuing monitoring and advanced therapeutic strategies in the setting of PBC. So let's get started, Ann. Tell me a little bit about what is a response in the setting of primary biliary cholangitis. What do you want to see when you're treating patients with ursodeoxycholic acid?
Sure. I feel like we could get into a real discussion about what our treatment target goals are. And if you go around the world, Barcelona, London, Toronto, here in the U.S., there's a different target that is considered adequate response. I think with our experience in the PBC clinical trial world, we got attached to that less than 1.67 times the upper limit of normal as being where we wanted our patients to land. Now, over the years, we have the Global PBC Study Group, which is a conglomerate of hepatologists from around the world who, because this is a rare disease, let's face it, we need a big N to look at this and what is response. And it turns out that an alkaline phosphatase that's truly normal predicts better outcomes for our patients at 10 years of transplant-free survival. And the same goes for bilirubin, where that target should really be 0.6 times the upper limit of normal, which equates to a bilirubin around 7, depending on what your upper limit of normal is for your lab, right? And there lies another problem. What is normal alk phos? I think many labs have different upper limit of normals. We see that with the 2 new PBC second-line therapies in their clinical trials. They had different upper limit of normals for their studies. And we never do head-to-head comparison, but it's made more difficult when we don't all agree on the same thing. And in my world, I feel like normal is normal. The target that I want to achieve for my PBC patient, where I feel most comfortable about preventing progression to transplant or death, is like a true normal alk phos. And so that's what I'm looking for, but I do individualize treatment based on risk stratification when it comes to fibrosis as well. So early stage disease in an older patient who doesn't want additional therapy, I might be more relaxed about, but certainly I'm much more aggressive in a younger patient that already has signs of fibrosis.
Absolutely. Thank you for that. So when you think about patients who are started on urso therapy, and I agree with you, there's so many different ways that people define response all over the globe. If you ultimately have deemed them a non-responder 12 months, 18 months, 6 months down the road, at that point, maybe you're considering therapy. When patients are thinking or entertaining the idea of adjunct therapy, they'll sometimes wonder, well, what if I don't do that? So let's talk a little bit about the patient who is a non-responder. What happens over time if they're left undertreated? What would you expect?
So I feel like we see this a lot because we know that about 40% of patients on URSO, which is first-line therapy, are not adequate responders. And the other thing we see is that 50% of patients with early-stage PBC treated with first-line therapy actually progress to a more severe stage within 5 years. So we see this all the time in our clinics. And I think maybe not you or I, but in the community, there's reluctance to use second-line therapy, sometimes because there's fear of associated side effects, perhaps. But now we have new options, and I still believe the first option for second-line therapy is not a bad option. So I want to do everything to prevent that eventual transplant. But I just feel like, really being on top of that patient, looking at where you want to be and monitoring, because if you don't, or if a patient refuses additional therapy, what you're going to see is a variable progression to advanced fibrosis. What you see with advanced fibrosis and early cirrhosis is a risk for hepatocellular carcinoma, which becomes real. We need to begin surveillance. In my clinic, we start with F3 disease and do ultrasound and AFP on an every 6-month basis. I'm not allowed by insurance to throw in an MRI or a triphasic CT, unfortunately, unless there's an abnormality on the ultrasound. I know around the country and with academic centers, a lot of times MRI is the first choice, or at least alternating MRI with ultrasound. Some areas can't do that or don't have the access. So you're starting that, early, because we see HCC in patients with PBC who are non-cirrhotic, actually, or maybe on the borderline. So I start worrying at F3 disease by non-invasive testing, my best assessment of F3 anyway, which could be, there's a little wiggle room there either way, right? And then watching the AFPs. The other thing I worry about is esophageal varices. Portal hypertension develops sometimes without cirrhosis, also in PBC patients. So if you're getting routine imaging on these patients and you start seeing changes associated with portal hypertension, even on labs, if your platelet count is declining, if on imaging you're noticing that spleen size is increasing, then I would begin surveillance for esophageal varices and consider non-selective beta blocker like carvedilol.
Yeah. So when you think about that patient that maybe either opted, and I've had this happen before, they were prescribed therapy, they kind of unfortunately got lost to follow-up, maybe discontinued therapy because it's expensive. Now they've unfortunately developed evidence of advanced fibrosis. They have the associated complications with that. When those patients are brought back in and you're providing counseling about now this is the new thing, these are the additional things we need to be looking at. You talked about hepatocellular carcinoma surveillance with every 6 months, and I agree with you that alternating modalities is nice if you have access to them, ultrasound versus MR, but not everyone is able to do that. You'd also mentioned screening for esophageal varices. So the patient that you screen that has no evidence of esophageal varices, what kind of timeline are you looking at repeating that?
So I would say it depends on how concerned I am about the patient and what their imaging findings are, but probably in 1 year to 2 years, I would repeat an endoscopy.
Okay. And for primary prophylaxis, you'd mentioned carvedilol. In my experience, patients seem to tolerate that okay. Are you doing any additional counseling for patients that are newly started on carvedilol as far as like what to be watching for with that risk of GI bleeding and or complications associated with that?
I mean, we talk about what GI bleeding looks like.
Yeah.
Obviously, you don't want a massive GI bleed. That's pretty obvious about what's happening.
Right.
But also watching stools for black tarry stools. We're watching labs to look for a decline in hemoglobin. A lot of times, these patients are not just going to have a massive GI bleed. They're going to have kind of a slow decline in hemoglobin, and then you go in and say, oh, what's happened?
Right.
And there's varices. So, I mean, having that discussion with what the future could look like for the patient is important, but I also try not to worry them. And I think carvedilol is very well tolerated. There's not a pulse goal with carvedilol, which thank goodness.
Yeah.
But the issue with beta blockers in our PBC patients is they already have a component of fatigue. And so I feel like beta blocker can add to that. And some patients just do not tolerate it. And then it's like, well, you can try the lowest dose. I still feel like I need to do something. That would be somebody that maybe prophylactic banding would be important to do, rather than wait for a problem. Right?
Yeah. And I've had patients at times who are so intolerant to the beta blocker that they'll actually opt for prophylactic banding. But
until they have it.
Until they have it, right.
And they're like, what was I thinking?
Then it's a different story. Yeah, absolutely. And so then obviously the trajectory over time, that advanced fibrotic patient with complications may move on to liver transplant. So what are the things that you're looking at, a kind of MELD score that you use as your criteria?
I feel like we skipped over one thing, and that is the bone health of these patients.
Sure.
Which I mean, if you're not on top of it now, post-transplant is going to be a problem.
Yeah.
And, just really paying attention to preventing fractures in our cholestatic patients is so important, especially when they're, important in general. But if they go to transplant, the risk becomes even greater that they're going to have a bone metabolism related fracture. Like it just is it's a real thing. And we have patients who are crippled, with fractures related to their osteoporosis, which I feel like we need to be definitely paying attention to that. Where I'm looking for a MELD score to be when I no longer am associated with a transplant program, so I'm sort of like a broker. So I think, the programs in our area want a MELD score of 15 consistently. But if a patient has like other complications of cirrhosis, say they have ascites that I can't get on top of with diuretics, or they have intractable pruritus, or they have encephalopathy that I'm just struggling to manage, I'm going to send them to the transplant program and let them make a decision on whether the patient is ready or not.
Yeah. Completely agree. And thank you for bringing up bone health. That in my podcast with Christina Hansen, we touched on that. And that is such an important piece of managing our patients with PBC and our patients with advanced stage liver disease, because this is, as you say, it's something we want to be on top. We want to be aware of and on top of earlier rather than later.
And I don't know if you've seen this, but I feel like issues that are normally managed in the PCP realm, once a person has liver disease, suddenly become not managed in the PCP realm.
Right.
So what we think may be being managed is likely not. And so it's a good idea to always check about all those health maintenance items that you would expect a patient to be doing with their PCP, thyroid health, bone health, dental health. That's not PCP, but all of these things that we see plaguing our PBC patients, like checking up and really being like the driver of that health maintenance care for our patients that are likely to develop issues surrounding that.
So as we sort of summarize today's visit, really thinking about how important it is to be mindful of what happens for patients who are not responders to standard dose ursotherapy, which has been a great drug for many, many patients. But clearly there's a lot of opportunity now ahead of us with additional therapies that have been approved for our patients. I know there's a great deal of excitement in the PBC world amongst the patients that there are these additional therapies. It's been a long time coming. So it's an exciting time.
It really is. And it couldn't be a group of more deserving patients. I think the patients have been patient for a long time.
Absolutely.
And this is a frightening disease that really, we haven't had the ability to fully potentially change the natural history yet, but now there's hope.
And on that note, we will wrap up today's podcast. So I wanted to thank again Ann Moore for joining us today. It was wonderful that you shared your expertise. Thank you so much for being here.
Thanks for having me. Look forward to the next one.
Thank you.